Next is colonic cancer. I always get confused between colonic and rectal cancer. So colonic cancer, it's V7. 56-year-old man presents in your rapid access clinic with intermittent diarrhea for 5 weeks. His GP has noted that his hemoglobin is 11 gram per deciliter. The history is otherwise non-contributory. Abdominal and rectal examinations are unremarkable. So how will you investigate him? So it's written so much in the book that I would manage this gentleman according to the NICE guidelines of colorectal cancer published in 2012. I would advise him more than one investigation needed. I would offer him colonoscopy and biopsy. I would suspicion he needs a contrast and CT thoracic abdomen pelvis. If no contraindication, he will need MRI of the pelvis. If he is unfit or comorbid, I would offer him flexible endoscopy and CT colonography. But balance should be given between the gold standard colonoscopy versus CT colonography. And a colonoscopy must see ileocecal valve but carries the risk of perforation and bleeding from the polypectomy. CT colonography picks up to 6 millimeter polyps, and below that all are missed and barium enema, apical core stricture. What symptoms are considered low risk for colorectal cancer? Patient with no anemia, no abdominal mass, no rectal mass. Patient with rectal bleeding with anal symptom, no persistent change in bowel habit. Rectal bleeding with obvious external cause, anal fissure, all ages. Change in bowel habit without rectal bleeding. Transient change in the bowel habit, particularly to harder or decreased frequency. Abdominal pain as a single symptom without sign symptom of intestinal obstruction. Soreness, discomfort, itchiness. So in these symptoms, patient will be referred via 2 weeks wait time pathway, but these are low risk for colorectal cancer. What symptoms are considered high risk for the colorectal cancer? Rectal bleeding with change in bowel habit to looser stools or increased frequency of defecation persisting for more than 6 weeks. Change in bowel habit as in the preceding without rectal bleeding and persisting for more than 6 weeks. Persistent rectal bleeding without anal symptoms. Palpable right-sided abdominal mass. Palpable rectal mass, unexplained iron deficiency anemia. What is the natural history of the colonic cancer? The majority of the colonic cancer arises from the pre-existing adenomatous polyp. So adenoma carcinoma sequence. 50% of the cancer arises on the left side and 20% on the right side. 5% cases are synchronous. So what evidence is there that the majority of the colonic cancers arise from the pre-existing polyps? So prevalence of adenoma correlates well with that of carcinomas. Average age of adenoma patients is 5 years younger than the patient with carcinoma. So adenomas are found in up to 1/3 of the colon's resections. Incidence of colorectal cancer has been followed with screening program involving colonoscopy and polypectomy. So what is the genes affected in the colon cancer? First one is APC gene, then KRAS, and then PB53. So what risk factors are known for colonic cancer? Again, older age is a main risk factor for the colon cancer. Risk double in the patient with the first degree relative colon cancer. 54% colon cancers are preventable. 28% caused by eating too little fiber. 20% are caused by eating to genetic factors that FPC and HNPCC. There are so many other lifestyle factors can be risk decreases with the physical exercise, dietary fiber, calcium, garlic, non-starchy vegetables and pulses. And risk increases with obesity, red meat, processed meat, alcohol, animal fat and sugar. Predisposing conditions: Crohn's disease, ulcerative colitis, previous gastric surgery, previous ureterosigmoidostomy. So at colonoscopy, your patient is found to have a colonic large functioning tumor in his cecum. Biopsies confirm invasive adenocarcinoma. His staging CT suggests localized disease. What will you do? His staging CT suggests localized disease. What will you do? So consent him for the right hemicolectomy. What are the principles of surgery for the colorectal cancer? The tumor must be radically excised with the vascular pedicle and accompanying lymphatic drainage. In an unfit patient, limited resection. Mechanical blood pressure is no longer required. Discuss oral antibiotics with mechanical blood reduction in the osmotic leak rate and reduction in the wound infection. There is no evidence for routine pelvic drain placement. Perform open or laparoscopic cystectomy. Mortality should be less than 5%. Elective operative mortality should be less than 5%. Wound infection rate less than 10%. Oral leak rate should be less than 4%. Extent of the bowel resection depends on the tumor site. Ascending colon cancer, gynecomastia dividing the ileocolic, right colic, and the branch of the middle colic artery. Descending colon left hemicolectomy, divide the IMA and splenic flexure cancers. Two options: extended right hemicolectomy or left hemicolectomy. Anastomosis should not be under tension. You have to take a right hemicolectomy. How do you fashion your anastomosis? So I used to do functional side-to-side anastomosis with linear stapler. How does colon cancer spread? So it spread direct, radical, lymphatic, um, bloodborne, and transluminal. So direct, it can spread longitudinally, radially, or transversely. Radial spread is most important in all the ureter and duodenum. Lymphatic spread, paracolonic node, paralytic node, 30% skip a tier of nodes, and rare for colonic cancer does not breach the muscle wall and have been to the lymph nodes. Bloodborne, most common site is the liver by portal vein, 50%, and other side include the lung, 10%. What is the survival rate for colon cancer? So 58% net 5-year survival rate and 57% 10-year survival rate. Survival is improving over the time. What do you know about staging of the colon cancer? So it's TNM staging. T1 submucosa, T2 musculorythmic propria, and T3 invading the serosa, breaching the serosa, and T4 a direct invasion of the organs, the structures. And N nodes, N1 is 1 to 3 nodes, N2 is 3 to 7 nodes, and more than 7. Okay, and distant mets M1, distant mets M1A, mets confined to one organ, M1B, one than more organ, more than one organ, and M1C, mets to the peritoneum. So it further divided the N staging, N1A, 1 lymph node, N1B, 1 to 3 lymph node, and 1C tumor deposits, and that's it.